I'm Dr. Gershon, and since my office manager's suddenly ill today, I'll introduce myself, and no drum rolls or anything like that. Before we get started, and this will be pretty casual, definitely you're going to have questions because this is a very, very interesting topic, regenerative medicine, stem cell therapy. But hold them till the end, and we'll do a little question and answer session, and then as I said earlier, we're going to hold our questions on, and I'll explain the costs of these things, and for joint injections, intravenous injections, the difference between when we use your own adipose tissue stem cells versus bone marrow or umbilical cord cells, umbilical cord blood stem cells. And so I'll go through the cost at the very end. And then, since Vanna is not back there, since my assistant Kate isn't here, we'll figure out a way to set up some times or check mark, and I'll give you a call tomorrow, and we'll certainly set up some times to meet privately and go through things with you. So, okay? So with that, I'm Dr. Gershon, and my background is fairly diverse. I'm board certified in 3 specialties, in primary care, family medicine, primary care sports medicine, where I was the head team physician at the University of North Texas for 20 years before I moved here in 2010. I'm also board certified in anti-aging and regenerative medicine, and really that's where my sports medicine background is what led me to get really excited about regenerative medicine. So we're going to talk tonight mostly about stem cells. Of course, regenerative medicine takes in a lot of things, from nutrition, from hormone therapy for men and women, and we have a lot of patients on hormone optimization programs, testosterone, all hormones for women, growth hormone, many different things, as well as vitamins and nutraceutical products and so forth, IV vitamin therapy. We have a hyperbaric oxygen chamber. We do a little of everything. But that interest and excitement about my years of sports medicine, both at the collegiate and professional levels and Olympic level. I've been at the Olympics and worked with a couple different Olympic teams. Most recently, the U.S. freestyle ski team. Got to go to Chile with them for 3 weeks in the summer a few years ago, and live my dream, because I grew up in northern Michigan, a ski racer. Hence why I always wanted to live in Aspen. And I just completed about 3 weeks ago, after 4 years of part-time study, my stem cell fellowship through the American Academy of Anti-Aging and Regenerative Medicine. I started doing stem cell therapy about 5 years ago. I was one of the first in the country, and I had previously had a medical spa in Dallas, and I had done over 100 cases of body contouring procedures and thrown away liters of fat. And when I learned that those were stem cells that we were disposing of, I was like, I got to learn this technique, because this is, I'm pretty good at that. And so hence we did. And when I started, there's now many, many IRB studies, Institutional Review Board studies. There were 3. Osteoarthritis, emphysema, and diabetes, which we still treat those. And now there are many, many, many more. We're finding out every day new indications for stem cell, from rheumatoid arthritis, MS, Parkinson's, macular degeneration, kidney issues, severe peripheral vascular disease, a number of things. So I'll go through some slides tonight. Most of it will be about osteoarthritis, treatment of knee pain, hips, shoulders. We've done it all. Partial rotator cuff tears. I've treated guys as young as 28 and as old as 88. And with good results. And it's a very simple procedure done under local anesthetic. It's very safe. There's never been a death in the United States from the use of what's called tumescent anesthesia, which we use to harvest fat cells. Most people are willing to give up a little bit. And if you don't, because there's a couple here that may not have much to give up, we can use bone marrow. We also use umbilical cord stem cells, which is rapidly becoming one of my favorites, because we're seeing tremendous use in older patients, patients that have systemic disease, emphysema, diabetes, macular degeneration, MS, Parkinson's, because those young cells that are a day old when they're harvested undergo a rigorous selection process, and they have to be 97% pure. It's a very selective process to be able to use those cells, and then they're rich with growth factors, cytokines, factors that stimulate your body to send more stem cells to an area when we use them. So they're really exciting and kind of a rapid growing part of what we do. So what's stem cell therapy? Well, we're going to talk about it. Excuse me. And I will get a little water from time to time. I'll try to keep that over here for our camera friend. You hit the edit button. Excuse me. So stem cells are those cells in your body that are responsible for repairing tissue. And you've had them. They've been active when you didn't know they were or not. You know, they've been active since birth. If you sprain, have a ski injury, you were saying something about your shoulder, skiing in a pole that went the wrong way, sprains, strains, bruises, you know, that's the first cell to go and go to that area to repair tissue. And specifically in the case of your joints, they have a hard time getting there. And that's why as we get older, our joints deteriorate. The joints, the cartilage surface will become degenerative, macerated, thinned out. You know, they wear out over time. Your body can't get the repair cells there. There's not a good blood flow inside of joints. And so the technique, and we'll show you how that works, is where we can isolate those cells from your body, or in the case of umbilical cord, and then we mix them with PRP. You may have heard of PRP, platelet-rich plasma. I've been using it for athletic injuries for way more than 10 years. We also use it, and you may have seen some of the brochures in the back, for hair growth and regeneration, for facial rejuvenation, for sexual wellness, many uses now for PRP, but we've been using it for a long time in the athletic setting prior to this. And so there's different types of stem cells. So the first thing the public generally says, hey, isn't that illegal? Isn't that banned? Those are embryonic stem cells, and President Bush, a number of years ago, signed an act that said no embryonic stem cell use in the United States. And I think it's a good thing, not just from ethical and or political issues, but those cells can become anything, including a cancer cell. Your body's own cells are going to become, and I'll show you a slide in a moment, they'll follow what's called a cell lineage. If we put them in cartilage, they're going to grow cartilage. We put it near a tendon, it's going to grow tendon. The vascular system, they're angiogenic. They help form new blood vessels. So we'll show you many things with that. So the adult stem cells, MSCs, mesenchymal stem cells, are cells found in your body in bone marrow, fat, skin, teeth. You know, they're in everything. They're responsible for new growth. So we don't use embryonic stem cells, and there are still some places outside of the U.S. where they do. I just think the risk is too great, and even if we had it here, I would not recommend it. So mesenchymal stem cells, again, create everything that makes us us, from bone marrow, cartilage, muscle, nerves, other tissues. Okay? So this is kind of a busy scientist doctor slide, and my pointer works not on the TV screen. So these are what we call cell lineages. So we're able to harvest this immature mesenchymal cell, and when it's put into the osteogenic pathway, it creates bone or cartilage, muscle, marrow, tendon, ligaments, you know, other tissues. And so we're able to take an immature cell that's called multipotent, that has the ability to become any cell in your body, and we can direct where it goes. And so where do these periocytes and mesenchymal cells live? Well, in a normal injury process, and I'll go over this kind of quickly, they kind of hang out along blood vessels, and then they can migrate in the vessel and go to the area of injury. These are your smart cells. They know way better what to do than we do ourselves. And so they're really quite amazing. They have immunomodulatory effects. They modulate the immune system. I have a patient, it's been almost 2 years since I injected him now. He's been on a hormone therapy program with me for about 3 years. He's only 48, but he's had rheumatoid arthritis since he was 15 years old. He lives down in Grand Junction, or he'd probably really be excited to come tell his story today. And when I see him, he's always, I know you're going to say I'm crazy, but within 2 weeks, I didn't have rheumatoid arthritis. And 2 years later, you know, he couldn't get out of bed in the morning without his feet hurting. He was on some very serious drugs that are pretty toxic to your body, and he doesn't take anything. Occasionally, maybe an ibuprofen. But so how does that work? That's a great question. We know it modulates the immune system, and that's about it. And he said, hey, I just want to try it. And so he had tremendous results with that. And so it's pretty exciting. So that's kind of how it works. Immunomodulatory, and those cells migrate to try and go repair processes. They're also angiogenic, which we'll talk about, and I'll show you some slides. They help form new blood vessels. That's how they have activity and effects with erectile dysfunction. In erectile dysfunction, obviously, we want to make sure someone's hormone levels are at an optimal level, because we can't function sexually unless all our hormones are balanced at any age, and so we see great results from that. But intravenous stem cell helps create new blood vessels and improve blood flow to every organ, including our sexual organs. So where do they come from? Well, they're in bone marrow, and there are some people in Colorado using bone marrow. The clinic that I'm partners with in Denver is now swinging over from bone marrow into more adipose, because we get such, it's easy to find someone that's ready, willing to donate fat versus going through a bone marrow biopsy. And there's 5 times more mesenchymal stem cells in adipose tissue than bone marrow. So why not do a technique that's less painful and easier and gives us a much higher yield? Now, I'm not saying it's easy from my standpoint. It's more labor intensive for me than doing a bone marrow biopsy, but it's virtually pain-free, all done under local anesthetic. I'll describe the procedure a little bit more and answer any questions you may have about how we do that with pre- and post-operative instructions, what do we look for, etc. But I love them because everybody would like to give up some. So those cells, wherever we harvest them from, are anti-inflammatory in nature. As I mentioned, they can help to modulate or regulate an overactive immune system. They certainly promote healing. I saw, well, where do we get our information now? Facebook. So I saw some pictures on Facebook. My sister-in-law messaged me this and showed me pictures in a burn unit where they have a gun they're using now, where they're taking stem cells, and I believe it's either saline and or PRP, and it sprays. It creates a mist, and they're spraying the cells on severe burns, and they're using stem cell topically in burn units, and the healing is unbelievable. You know, it really is. And so it's only a matter of time until you see stem cells used in every hospital, in many, many locations, and it's a growing, a rapidly growing field, probably the fastest growing section of medicine there is right now. Promote healing, as I said, they're angiogenic, and they form new tissue. We have researchers in labs growing bladders and ligaments and tendons, and so, you know, the future of stem cell is huge. In the United States, we can't culture expands stem cells. It's only legal for same-day use. If you go out of the country, you can take your fat harvest. They can grow those cells for about 30 days, do multiple divisions of them, and create, you know, we get maybe 80 million, which is a lot of cells, 70 to 80 million per this technique. They could quadruple that in a month's time by growing. But the FDA says we're creating a drug, and that's not legal. So there is no culture expansion in the U.S. at this time. That would be great, because then we could harvest your cells now, start expanding them. You can go home, fly back for skiing, or go fishing this summer and get your stem cells back in a huge number. So I find that pretty exciting. So what is the procedure? So I'll explain to you in the case of adipose-derived stem cells how we do this. We use a local anesthetic to numb the area in your abdomen. We use a little cannula to insert under, we use about a 1/4 inch incision on each side of the abdomen. Maybe we're doing the lower abdomen or upper, wherever that's at. And we pass a fluid in there with a cannula. There's no nerve fibers in that fatty layer, so you only really feel the numbing shot initially. You don't feel the incision, and then we fill that like a water balloon, so to speak. Not a big one, but we just put some fluid in that layer to make it tense and easy to just pass another cannula in under suction and remove those cells. So for a knee, for instance, we would harvest about 60 cc's of fat. That's 2 shot glasses. So I usually, people always say, can you take more? Well, yes, I take more. I take more in case I drop it. So, you know, we always take a little extra and have it in our sterile flow hood in case we ever needed more. But we need 60 cc's. It can be done in thin patients with as little as 45. I've done it once with 30, and the patient still had a good results. But I mean, I worked hard to get that little amount of fat. And so generally we have it. We can find it on the buttocks, inner thighs, tummy, love handles. You know, usually a little extra fat isn't hard to find. I've only had one that was a close call. And now that we have umbilical, though, you know, there are many reasons to want to use those cells as well. Certainly for in intravenous and metabolic conditions, we see, you know, good results with that, great results. I just talked to a guy yesterday. I called down at Grand Junction that I did his ankle 6 months ago. He had a fusion, and his surgeon, who's now an ankle moved to Aspen, Dr. Khan Faruqi, who's a friend of mine, he had fused his ankle. And his ankle, it just, you know, sometimes when we do these fusions, they don't always take, they still have pain, and I talked to him, he had done everything he could do, and he's an excellent surgeon. And he said, hey, go for it if you want. And so we did, we injected his ankle, and then he came back 1 month ago because he developed emphysema and really having a hard time. He's like, I want an IV. So I gave him an umbilical cord IV for his emphysema. And I called him yesterday, and he's only 4 weeks out. His breathing is significant. I could tell as soon as I heard him on the phone. He wasn't gasping, he wasn't short of breath. I mean, he's like, I feel great, and I have no pain in my ankle, and it had been a 10, and a 10 for a long time after multiple fractures and then an attempt at fusing it. So umbilical cell cord blood cells are also producing pretty dramatic results. So when we do this procedure for fat cells, then we harvest them, and then we have to process that tissue. So it takes me, I did one the other day in 10 minutes, usually 12 to 15 minutes. Patient's wide awake, it's all done under local. You go back and hang out in the room, and then I go in the lab to work for about an hour. And it takes about an hour to isolate those cells. If we're doing a joint injection, then we'll come draw blood and spin that blood to obtain the platelet-rich plasma. Combine it with the stem cells and then do the joint injection. Why? Because we want the cytokines and growth factors to stimulate those stem cells to go to work. I like to do a follow-up PRP injection in a joint at about 6 weeks, a month to 6 weeks out. It's not mandatory, but I get better results because it reduces more inflammation, puts in more growth factors, and helps to nourish those new cells that are becoming, you know, fibrocartilage. And so in the case of intravenous injections, we don't have to draw your blood because we're putting the stem cells mixed in saline in with the growth factors in your blood. So, you know, we don't have to draw it and give it back. So, and how are they administered? You know, I know that there's folks here that have had cortisone injections. It's a joint injection. You know, in the case of hips, we do it under ultrasound so we can be very precise with where it's going. Hips and shoulders, we like to do ultrasound. With knees, it's very simple to follow this technique and get right in the center of the joint, get the cells there. And I've had just one patient with knees that didn't quite get the response he had hoped for, but otherwise we see, and I'll go through the statistics with you, a very significant improvement in pain. So how can they benefit me? Well, they help repair tissue that's been damaged or destroyed, whether you've had to have repeated cortisone injections to put the fire out. And we've done that for a long time. I don't do that much anymore. I'd rather give someone a PRP injection and let the platelets and the growth factors reduce inflammation. then use cortisone, but you know, a lot of doctors still do. When you're at that point, there's nothing else to do, it's very effective because it reduces inflammation. But we know long term that it's not good for your cartilage, that it causes further degeneration of the cartilage. And so it's kind of buying time until you have that joint replacement. And so if you can't, because of age or because of other factors, or you just don't want to, you want to stay active and not risk the replacement and the infections and many things that can happen. They don't happen every time. There's some great surgeons here. There's some, you know, a lot of great surgeons. They get excellent results. But it's a decision. If you're not ready for that, then this is the alternative. And there has never been an alternative before. And so that's why I share this. I promote healing in many other injuries, genetic and degenerative diseases, like I mentioned with my rheumatoid patient, Parkinson's and MS, etc. So this, as a sports medicine doctor, what got me excited was being able to do something else for osteoarthritis. You know, I've sent patients to my surgeon buddies for a long time when there wasn't anything else to do. If I had something that could buy them 3 years, 5 years, 10 years, or put off a replacement, well, why not? So we know, so osteoarthritis, and this is an x-ray of a shoulder, and you can see the narrowing joint space behind the ball of the humerus, is characterized by wearing down a cartilage. And then somebody mentioned bone on bone earlier. Well, that's just not something we see on x-ray. That's something, well, when we see it or whether we don't, it causes what? Friction, and it causes inflammation and pain. And so if we can do something to help regenerate worn cartilage, decrease inflammation, decrease pain, and in many cases increase range of motion, would you say that's worth it? Yeah, absolutely. And so we see, I'll go through this. This is just a knee, similar findings, same thing, same benefits. It can help heal partial ACL tears. So if there's a knee that's a little loose and there's a partial tear, it's not going to bring back together a complete tear. You know, I tore my left ACL and MCL ski racing a year and a half ago in the NASCAR National Championships. I caught an edge at the bottom. I thought I was still 21. And the night before, set my bindings to 12 so they wouldn't release. And they didn't, but my knee did. And so I had a complete reconstruction, and I've had 3 stem cell injections because when I dislocated the kneecap, it took all the cartilage off the backside of my patella. So I could barely even do my rehab. I was released from the surgeon 4 months after the procedure from the ACL. He's like, oh, feels great, nice and snug, good, keep doing your exercise. I'm like, I can't, because every time I did anything, it would swell up so bad that I just couldn't. And so I went a month after surgery to my trainers in Miami and had an injection. I went again at 6 months and at 12 months. And I skied all weekend last weekend. I have no pain, no swelling, and you know, it's amazing. You know, so for me, I'm very, very happy and excited about that. So you know, this is just data, and people say, well, how's it work, or what do you expect to see? So this is some data from some of the IRB studies that we were part of initially. This was on 103 patients, some standard questionnaires when you have an injury that you might get, a short form pain questionnaire, a visual, it's called a visual analog scale, where you get a little line from X here to here, you mark a line. My pain is there. It's an 8 or 9, and then we measure it in millimeters, and in 3 months and 6 months you have to mark that line again without seeing what you did last time. And nobody ever remembers where they put the X, and so you'll see the results of that. They're significant, a reduction in pain. On average, we see about 75, I would say 70 to 80% reduction in pain. The gentleman I told you about his ankle today that I called yesterday, his pain was a 10 and had been there a long time. He's like, I don't have any pain now. It doesn't hurt at all. So great for him, but on average we see 70 to 80% reduction in pain. This was just at 6 months. So I tell people you start to notice a difference anywhere from 2 weeks to 12 weeks, 2 to 3 months. It peaks at 6 months, but these cells continue multiplying and growing for 12 to 18 months. So, you know, it's not over till it's over, or the fat lady sings, or however that goes. But so they really continue to work for quite some time. This short form questionnaire, 75% improvement over baseline. Present pain inventory, how do I feel today? You know, I was a 10, now it's a 2. We see at least 60% average at 6 months reduction in pain. And that's just 6 months. Like I said, that process continues. So that we mentioned earlier, someone asked about, is one enough? And in all of the patients except my knee and one other guy that I've worked on out of 100 and some, it is enough. But he said, you know, he had had a knee, and it was a 9, 10, it hurt a lot, and he had no pain for a while, and he called me after a year and said, you know, it's about a 2 or 3, I think I want to do it again. Can I? I'm like, absolutely. So it's a scaffolding effect. If we need to do it again, it's just going to keep repairing and building more cartilage. Will it prevent you from going out and falling or twisting your knee and tearing meniscus or having another injury? No. I mean, anybody can, hopefully that won't happen on the way out of here today, but anything can happen at any time. But we know that we don't generally expect to have to do a lot of repeated injections unless the severity would warrant it, and that's something we can kind of talk about going into it. So this is a condition called avascular necrosis. This is something that isn't well treated because those bones, when we get this after an injury, a direct bruise, they don't heal well because there's not, as we mentioned before, a good blood flow, right? Your periocytes and stem cells can't get there well. And so you can see on pre-treatment MRI these areas that really light up. Well, those are areas that are injured and or dying. In the case of the hip, you guys may remember a Heisman Trophy winner from years ago by the name of Bo Jackson, played for the Oakland Raiders for a while. He had avascular necrosis of the hip, had a hip replacement, his NFL career was over. Do you think he might have had a stem cell injection? Absolutely. Why? Yeah, because why wouldn't you? Because we know for sure he's not going to play football with a hip replacement. So I share that, not that any of you have this issue, but I share that because it's significant and it's how powerful stem cells are. This is healing in a ligament that, I apologize, my pointer doesn't shine on the TV, but this is pre-treatment. This is a ligament in Cutter, who was a racehorse at 13, this kind of injury. Might have gone to glue, I'm not sure, but this is, in this area you can see the tear in the ligament. You can see 30 days later, 60 days, and 6 months, complete healing in that ligament. And so, you know, we are able to look at tissue and these kind of things on an animal. Obviously, we can't share that with you on humans, but this is how it heals and what happens. And they've been using stem cells in veterinary medicine for a long time. Before, in the U.S., many years before we've been able to do that safely on human beings. So the next thing I want to share, I'm going to share a little testimonial with you, and I'll have to step over to press start. It's real short. But this is a woman who was a diabetic, not doing well with her diabetes, gaining weight, taking multiple medicines, I think 3 or 4 oral medicines, long-acting insulin, short-acting insulin, and this was just a few months after her stem cell therapy, and I'm going to let her just tell you her story.
Different kinds of medication, trying to take care of this problem, and I was basically on insulin twice a day, as well as taking metformin twice a day, glyburide, and Actos. The problem was it just kept getting worse, and then I found out about Dr. Gershon's new program to try with a stem cell. Well, anything is better than doing nothing, so I went for it, and I had the stem cell done. The exciting thing is, the only thing I still take is metformin, and now for the first time in 35 years, I'm not hungry all the time. I've got the energy to do my work. I'm able to exercise and do what I want to do. I hope to, the weight is falling off.
So that's Phyllis. And the weight's falling off because she doesn't have insulin resistance anymore. And so those cells have helped her not only circulate in your bloodstream. Some of them, in the case of diabetes, make it to the pancreas and help regenerate pancreatic beta cells, cells that produce insulin, but they also have an effect to help reduce insulin resistance. So what we do have is more active. And we know when insulin levels are high, we gain weight because it blocks what's called lipolysis. That's why when you eat a high-carb diet, your insulin level comes up, you stop burning fat for 4 to 6 hours. And so don't eat carbs. But in her case, the stem cells were able to help lower her insulin resistance, help her to stop taking insulin, and her results were great. So I want to share some slides as well of something just called critical limb ischemia. You don't have that or you wouldn't be skiing or hiking, but in cases, I mentioned that these stem cells are angiogenic, they form new blood vessels. So this is just a schematic of doing injections along the soft tissue in the lower extremity, and of course the resultant improvement in the way the skin looks. What I'll share with you is the arteriogram. This is a leg, and at about this area is the ankle and below, and you can see there's not much blood getting down there. This is what it looked like after the stem cell therapy. Significant. And so those are the effects. I don't expect that we're going to treat you for critical limb ischemia, but when you wonder, well, how does it help erectile dysfunction? Well, how does it not help when it improves circulation to those degrees? And so that's pretty exciting. These are just angiograms on the left before stem cell therapy, on the right afterwards, and you can see 8 months afterwards the fairly significant improvement in circulation. And so I want to talk about another condition that we treat intravenously, which is emphysema, or COPD. At this altitude, you can't really tolerate much COPD. Will put an end to your hiking and skiing career pretty quickly. So when we have this, we see our internist, our pulmonary specialist, we take inhalers, corticosteroids, bronchodilators, oxygen, but there's only so much we can do. It's probably been one of the most frustrating things when I was doing primary care that I treated, because once you're oxygen dependent, you don't go any place without the bottle. And I've had several patients that were able to stop using oxygen during the day, only use it a little bit at night if they felt they needed it, and that is a big deal. When you can work and continue working when you couldn't because of your oxygenation and shortness of breath. So let me share this video with you. I know this one's louder, so I'm going to turn it down in advance so you don't jump out of your seat in a minute. But let me play this for you. And I'll play it to the end because the end of this is my favorite part, when you get to see this gentleman who couldn't get out of bed and do anything for himself walk his daughter down the aisle. This was done when I started doing these treatments 5 years ago. You couldn't do this in the United States. You had to leave the country to get an IV injection. So he was at one of our sister facilities in Tijuana called Hospital Angeles, and so he's talking about them somewhat. But that's why. He had to go there and spend 3 times more than we charge for it now in order to have it done, probably $20,000 to have one injection 5 years ago. So I want to share that with you. Oop.
Ron Dalke. I've had COPD, or been diagnosed with COPD since the year 2000. And it's progressed to a point through the years that it got worse and worse and worse, where I didn't have to use oxygen for the first year or two. Then it came to oxygen, more medicines, hospital times, legs would swell up with nitrogen, ambulance would have to come get me. I wasn't able to walk. Until I heard about the regenerative medicine services, I thought there was absolutely no hope. That I was just destined to pass away, whatever, through the night, and that's how I felt. At times I felt that I wish God would take me and stop the suffering. I'm totally unable to bathe myself or do any chores around the house, inside or out. I have to get people over to do it. My friends come over, and I'm hoping that this will at least give me enough power in my lungs that I can start doing things for myself. Ron Dalke. I have COPD. I've had it for approximately 12 years. I searched out many hospitals across the world, and I settled on Regenerative Medicine Institute in Mexico because I found that this one seemed it would best suit my needs. In Canada, where I'm come from, they no longer, how can you put it, could do anything more for me. It was just a matter of question of when my time was going to come. Coming to the Regenerative Medicine Institute in Tijuana, Mexico, it has changed my life completely. Within the first 5 days, I seen a significant improvement. Within 2 weeks, I was able to ride my bicycle for 30 minutes at 7 kilometers twice a day. Within less than 2 months, I was able to walk without oxygen, to walk my daughter down the aisle on her wedding, and also was able to dance with her without oxygen. This is one of the best times of my life. I've since returned to the clinic for my second treatment. If it's anything like the first treatment, which I know it has been because I've already started to feel better, and I don't know what to say. I'm just happy, and the people at the clinic were fantastic to me. The doctors, the staff, everybody. I think the old big people in Mexico that I have met here have treated me with honor and dignity, and I'm very proud to be here, and I'm very proud of knowing you. Thank you.
You get choked up watching that. I've seen that so many times. I still get choked up, and that's why I play it to the end and hear him talk about the other hospital. But because it's significant, you know, this has been the most exciting thing I've done in 35 years of practice, and I love helping people. And when you can impact someone's lifestyle and the way they feel, and I got 5 kids, take their daughter down the aisle, it's a big deal to me. So we also try to quantify these things. It's one thing to do, as you saw, the analog scale and rate your pain. It's a 9, it's a 6, it's a 0, it's a whatever. A little harder to do with breathing. So we do St. George Respiratory Questionnaire, which quality of life measures, and then we also do a walk test, 6-minute walk test. The first woman that I did with emphysema about 4, almost 5 years ago, when she came to the clinic, we set out the cones and measured, and she had her oxygen with her. She went 80 meters, a little football field, let's say, in 6 minutes and stopped 7 times. When she came back 3 months later from Minnesota, she went 300 meters without stopping in 6 minutes, without oxygen, in 90 days' time. So that's pretty exciting, and this is just another schematic of the improvement in 3 months, 20-30% of the 6-minute walk test. So this is a big deal, very exciting. So why choose stem cell therapy? Well, why not? You know, it's natural therapy using cells from your own body. It may prevent surgeries, which, you know, aren't without potential complications. Certainly can avoid the use of pharmaceutical agents long term. It's very simple, effective, and done under local anesthetic. And so I didn't talk about a number of things. There's a lot of conditions that we treat, and as time goes on, it's just getting better and better and better. And I'm looking at some new equipment now that shortens the time involved in isolating the cells and all the things that we do to comply with the FDA, and it's exciting. It's just, you know, the future is really bright in this field. So with that, I will answer any questions that you have regarding medical stuff, and we'll discuss the finances at the end. So, does anyone have a question?
Like, have they used it with Lou Gehrigs at all? Is there any?
You know, the question was, have they used it with Lou Gehrig's disease? And there are many neurodegenerative diseases that are showing promise. We certainly are seeing improvement in Parkinson's patient, peripheral neuropathy, MS. There are some that not so good. And that Lou Gehrigs would be one that, you know, I would be amiss to say, oh yes, you know, could someone try it? I mean, there are a number of things. The time will tell. But at this point, not.
And I heard you mention macula or
Mhm.
degeneration, so.
So we are seeing improvement. I got an email from a patient in Grand Junction this morning that I didn't look at the date. It's been at least 6 months. I think it was early last summer, maybe somewhere. Let's just say 6 months. I did his knee, and while we're at it, he's like, "Just give me some." You know, he's had some severe problems with his eye, and he said, "My one eye has improved significantly. The other one, the field of vision is a little better. The vision hasn't improved a lot, but it was getting worse consistently, and it hadn't changed at all. My studies are exactly the same now at 6 months." And so he was really happy, and his knee, he had zero knee pain now. So we have had improvement with that as well. Yes, ma'am.
What about vertebrae?
In spine issues, so there are also protocols for lumbar disc injections, facet joints, sacroiliac joints. I'm not doing that here in Aspen. We're doing it in Denver in conjunction with one of my partners there that's a pain management doctor that does spine injections. We're just, you know, setting up a new room with that has to be done under some very special visualization. But yes, they're seeing help with that as well.
For high impact, how can we get improvement if you do like jump high
For
impact after the injections?
in relation to what?
To play volleyball and stuff like that. Like
So are we talking about a knee injury or with a knee injury? So with any kind of sport, we see a reduction in pain. So if you're talking about someone who's a volleyball player or does something with impact, certainly for a period of time afterwards, we want you to rest. We need those cells to have time to work. And so it's going to take 3 to 6 months. Now with that said, I did a snowboarder who the inside of his femur, one side of his knee was bone on bone. He's only 28, and from the rails and all the things they do in those parks. And he did not want to have a partial knee replacement at 28. And so he took it easy as long as he could, but I know within 3 months he got back out and it kind of flared up a little bit, but now he has no pain. So those cells go to work. As you saw from the slides, the improvement starts to really peak at about 6 months. So in the first 3 month, time period, you can ski, you can hike, you can cycle, but impact activities we would want to avoid because we need those cells to grow, not damage them. And so we know that they're going to continue to grow for 12 to 18 months. And so once they're well, you can do most anything to tolerance that you want to do. And so hopefully return to your sport, return to playing volleyball and doing things like that, having fun. Yes, sir.
Go ahead.
Okay.
No, you go ahead.
I was just also going to ask you about a knee.
Mm-hmm.
I have an arthritic knee that's bone on bone in one side of my knee. Through a lifestyle of dancing and exercise, I do take now pain-kill pills to stop the pain.
Mm-hmm.
I mean, I can still focus and work very well, but you're interested me in saying I'm sure that I would be, a candidate now for a knee replacement therapy, which I'm not keen to do at all. You're saying that your treatment could alleviate that possibility?
Yes, ma'am. Yep, and I like to look at the x-rays. I've kind of stopped predicting the outcome based on the x-ray. I've had a few, 2 or 3, that I said I don't think I can help you, it's too late. A lot of people say, oh, it's bone on bone, but we grade those x-rays 1, 2, 3, 4, maybe there are 3, 3.5. When there's no space left, it's going to help reduce pain, but it depends on your activity. If you're, and I don't want to use a number because age doesn't mean much anymore, but if your goal is to be a little more active around the house, that's one thing. If you want to hike and bike and do things outside again and it's like that, then the outcome may not be as good. But I've had probably 20 patients told to have a replacement that were, quote, bone on bone, that have little or no pain at this point, 6 months, a year, 2 years, 3 years later. So my idea of a patient that's a candidate is anyone that has moderately severe arthritis and doesn't want a joint replacement, wants to try something else. And we've been very effective with that.
So you need to see the x-rays to diagnose?
I like to see them, yes. We want to see it and look at them for sure. And there might be a chance, I'd say no. But it again, depends on what the goal is, what it looks like, and what the exam is, and knowing that we're going to get 70 to 80% reduction in pain in almost everyone, and many times better. Huh? Yes, sir.
Have you had, excuse me, have you had any experiences with SERVA? You know what SERVA is?
I haven't.
It's pretty much unrecognized illness. It's a vaccine injury, and it's recognized by the vaccine court. What happens is it's a medically induced problem where they go in with the injection from the vaccine, and they go into the joint. And what happens is the adjuvant creates a perpetual inflammatory reaction, so you start getting rotator cuff tears, and it seems to be perpetual.
Well, the question for that would be: is it from what did that injury do? Microvascular injury, blood vessel, and so certainly we know it can repair. Never heard of anyone treating that specific condition, so it would just be
just because it's unrecognized.
yeah,
right now,
it would be somebody that said, yeah, I want to try this. I don't want my shoulder replaced.
Well,
but
they may come in with just a rotator cuff problem, not recognize that it was associated with the vaccination.
right,
And it's easily avoided if they just stay away from the
move down where they're supposed to be. Yeah,
But it's actually a mechanical
Interesting.
problem that they get into the joint.
yeah, I haven't.
And it's
seen anyone
becoming
with that.
very common and now recognizing. So
Well, it would be the only possible treatment that could help to regenerate tissue.
Well,
There
I
isn't
understand
anything
that
else.
with stem cells, but I'm just wondering if you recognize it at all. Obviously, you're not real familiar
Yeah, I'm
with
not real familiar with it,
Most doctors aren't,
and
but
I've not heard of anyone treating that
I was
condition.
I was curious about whether it would stop the chronic inflammation that's creating
Mhm.
the ongoing perpetual.
Well, it would
degeneration.
it would make total sense that it
Yeah.
would. So, yeah. Anyone else?
I'd be interested.
Oh, go ahead.
Sorry. Go ahead.
So like I have an all injury surgery, the MRI like a long time ago, 15 years ago, MRI will be any use for you, or we need to start all over for MRI?
It's nice to have recent diagnostic studies just so we know the extent of what we're trying to fix. Certainly it's joint pain. Yes, you probably have osteoarthritis. It's kind of hard to go past 40 or 50, be active and not develop it. But it would make sense to look at some new studies. Yes, ma'am?
Just about cost, I think you're going to talk about that later.
I will.
Okay. I'd
Shortly.
like to talk about that.
Okay. Are there any other? You asked me a question earlier about antibiotics, pre and post-operative instructions. So I like to treat, even though this is a 10-minute procedure, I treat it just like I was doing a full body contouring procedure. So yes, I use preoperative antibiotics for about 5 days, 1 day before and 4 days after the procedure. I've never had an infection. I've done over 200 liposuctions and never had any kind of infection. So this is a very small area, but I still do it because that's the way I was trained. I do a full sterile prep and an operating room kind of set up in the clinic where we just drape, we do everything. That way I have you wash with a surgical soap called HibaCleanse the night before and the morning of to just eradicate any staph bacteria off your body. I kind of feel at times like it's overkill, but I've also never had an infection and I like that. So, that's what I'll keep doing. So, okay? All right, and so certainly we can answer any other questions one-on-one. My office manager's not here, so if you want me to call you in the morning, set up a time, put a big check mark where you signed in, make sure I can read your phone number, and I may be calling you because she's really sick. So one of us will call and help set up a time. Yes, sir.
One more question. Is this, I don't know if I missed it, is this approved by FDA?
This is not a drug. This is your cells. The FDA is well aware of what we do. It's not, this is the practice of medicine. And so it's not like approving a device or a drug. And so it's, FDA is well aware. They've just had a lot of public hearings. They're getting a lot of pressure from the pharmaceutical industry to try to regulate this. If they could patent it, then they would. but these are your cells in most cases.
Are
And so.
orthopedics, are they using this stem?
Well, not many. Many are. They're growing. It's, you know, this is a new field, and so, you know, the pioneers are there, and so they're coming on board. I know him really well. I used to.
That's my good friend. So I
Yeah.
was just
So he
curious
takes
if I
care of.
call Tark and say, hey,
He
what
might.
about
You
this?
can tell him I said hi because back before the Dallas Stars were there, I covered with him the Dallas Freeze hockey team in Dallas when I was there, and then he's one of the doctors for the Mavericks.
Right.
So, anyway, so.
Is this more recognized in Europe?
Well, because they didn't have a government and FDA and all that. Yes, we've been doing Israel, Europe, South America. You know, there's been a lot.
So it's been more accepted.
Yeah, it's been going on this time.
Rap or your stem cell, and you think about that.
Well, that was the whole embryonic debate and all that, but that's what led researchers to have to find another way. So why wouldn't we use your own? The populations are tremendous. There's just no question, we get tremendous results. It varies person to person depending on the severity of what we're treating and what the goal is. But there's literally no downside because they're your cells. You know, and even when we use umbilical cells, are undifferentiated cells that become host tissue. So